This is a tutorial on how to use ultrasound to quickly determine whether you have venous placement or have caused a pneumothorax from your newly placed central line. This will allow you to begin using your central line moments after placing it rather than waiting for more finalized confirmation from a plain film. The first step in this process is to place the central line to the best of your ability based on procedural guidelines in either the left or right subclavian or internal jugular veins. Be sure to approximate the length of the venous catheter insertion either by using appropriate formulas based on the site or close approximation based on the patient's body habitus. This will ensure that the catheter tip is not placed directly in the atrium. We can then evaluate for a pneumothorax in the same manner that you would in an EFAST. Place the linear transducer in the superior portion of the chest at approximately the 3rd to 4th intercostal space midclavicular line, with the marker dot pointed cephalad on the side of the chest where the catheter was placed. It is best to adjust the probe linearly until 2 ribs are seen on each side of the image. A pneumothorax will typically rise to the least dependent portion of the chest, so in the supine patient, make sure to image the most anterior rib space. What you should see is lung sliding of the visceral and parietal pleura noted here between the 2 rib spaces. This can also be seen using M mode showing the classic seashore sign. If there is a pneumothorax present, there will be a lack of lung sliding between the 2 pleura that can be witnessed here. This can also be seen using M mode showing the classic barcode sign. In this case, comparing one side of the chest to the other may be helpful. Another helpful tool is the presence of B lines or comet tails, seen here with the curvilinear probe, which indicate that the lung does not have a pneumothorax. Finally, in addition to possibly using the ultrasound guidance during insertion of the needle in the vessel, transducing the blood return, or examining the color of the blood, the technique we would like to focus on is visualizing passing of agitated normal saline within the right atrium. This can be done by placing the curvilinear probe of the ultrasound in the subxiphoid region with the marker dot toward the patient's right side or right shoulder. This view will then show the right ventricle immediately adjacent to the left lobe of the liver at the superior portion of the screen and the right atrium to its left. One would now take 10 cc's of normal saline and flush it through the central line. This would cause a flow of bubbles in the right atrium passing to the right ventricle, seen on the superior portion of the screen. This confirms that no matter where the precise location of the venous catheter tip, it is still in the venous system and can be available for use. A special thanks to Dr. Beck and the Emergency Ultrasound Department, who extended an invitation to those requesting to learn more about ultrasound landmarks or anatomy found in this video.